Hi, my name is Giovanni Filato. I'm the Director of Epidemiology at the Institute for Healthcare Research and Improvement at Baylor Healthcare System. I would like to share the result of a study we performed on assessing the best management for abdominal aortic aneurysm. The following presentation will provide you all the details. Thank you. It is estimated that 27 million people worldwide currently have abdominal aortic aneurysm. The management depends on the size. Surgery is recommended for large aneurysm. Surveillance is recommended for very small aneurysm. Management is uncertain for a small aneurysm. Costs are very high. In the United States, over 45,000 repairs are performed each year, and the costs are associated with the repairs are approximately $1.5 billion. Only for randomized trial compare surveillance to meet repair in patients with abdominal aortic aneurysm between 4 and 5.5 centimeters. Two studies, the UKSAT and the ADAM trial, compare surveillance to open surgery, while two other studies, the pivotal and the Caesar trial, compare surveillance to endovascular surgery. None of these studies show survival benefit associated with immediate repair compared to surveillance. Moreover, no significant difference in cost between immediate endovascular repair and surveillance was observed at 4 years in the pivotal trial. However, the UKSAT study showed significantly higher costs with immediate open repair at 12-year follow-up. In the present study, we compare survival in 2,226 patients with small aneurysm randomized to receive immediate open repair versus surveillance, overall and by gender, using the original patient data set from the UKSAT and ADAM trial. Basically, we pull the patient-level data of the two trials together. We then investigated an additional question whether survival difference existed between immediate open repair and surveillance depending on the aneurysm size, overall and by gender. Over the 7-year follow-up, we found no survival difference between the treatment groups in the overall study population. The overall adjusted hazard ratio was 0.99, and the 95% confidence interval were not significant. Likewise, no difference were found in the subgroup of men and women. Both hazard ratios were not significant. More importantly, the lack of treatment effect did not vary by aneurysm size, meaning that survival was no different between the patient in the surgery group and the patient in the surveillance group, even for those patients with larger aneurysm and therefore high risk of rupture, for example, between 5 and 5.4 centimeters. Likewise, the lack of treatment effect did not vary by aneurysm size in the subgroup of women. In conclusion, immediate open repair offers no significant survival benefit compared to surveillance, overall and also in the subgroup of men and women, even in those patients with highest risk of rupture. Combined with the failure of a recent trial to show a survival benefit of immediate endovascular repair over surveillance, our findings suggest the gray area of first line of management for patients with small abdominal aortic aneurysm should be resolved in favor of surveillance. Given that treatment decisions have to be made in the context of limited healthcare resources, the next important question that needs to be addressed is the relative long-term cost for each treatment option. If, as expected, surveillance is found to be the less expensive option, immediate repair of small abdominal aortic aneurysm could be targeted for reduction of inappropriate use or waste as part of effort to reduce unnecessary healthcare spending. I would like to thank you for the opportunity and for the privilege of presenting the work that my colleague and I carry out.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.com. This video content is copyrighted by Mayo Foundation for Medical Education and Research.